All right, so pharmacist interventions part 21. I had a patient who was in a motor vehicle accident and she broke her arm and she was discharged from the hospital on 3 medications: gabapentin, methocarbamol, Tylenol. And for those who don't know, gabapentin is a terrible choice for non-neuropathic pain. It doesn't really help at all. Non-neuropathic being non-nerve related pain. Methocarbamol is a muscle relaxant, and then Tylenol is just Tylenol. So I decided to call the hospital because I thought that her pain wasn't being appropriately managed. She's in an immense amount of pain in my pharmacy, and I wanted to help her. So I called the hospital, got a hold of the operator, and I was explaining the situation, how I didn't think that those choices were appropriate to manage her pain based off of her pain level, and then also like the severity of the incident, and then what medications were sent over. And I was requesting basically to talk to a provider so I could get something else, like maybe an opioid for her for the time being. And the operator refused to transfer me to a practitioner. So that wasn't good. I assumed that this was a case of racial bias because she was a Black woman in an immense amount of pain. I checked her history. She had no history of controlled substance fills. And I just didn't think that it was appropriate to discharge someone on those medications for a fracture like that. So I asked if she had a primary care provider. She said no. So I ended up just sending her back to the hospital because there was nothing more I could do if they refused to transfer me to a practitioner. Another intervention that I had was I had a patient who was a young male picking up levothyroxine 125 micrograms and liothyronine 25. So we basically have T3 and T4, artificial T3 and T4. So liothyronine is the active form and levothyroxine is not the active form. Your body metabolizes it into the active thyroid hormone. But I like to counsel patients or just like sift out if they're experiencing like symptoms of hyperthyroidism, like too much thyroid hormone, if they're on Cytomel and Synthroid, or levothyroxine and liothyronine when they're on both. And this patient was experiencing some symptoms of hyperthyroidism, being irritability, nervousness, anxiety, sweating, trouble sleeping, like insomnia. Some patients can also experience like heart palpitations, which is another side effect of things like that. And of course, like weight loss for like more long-term, or like Graves' disease. But he also was a type 1 diabetic, and it was his primary care physician that was managing the disease state, not an endocrinologist, which is fine in certain situations. But in this situation, I thought maybe he would need a specialist if it was being managed appropriately. Another intervention that I had was a patient picking up Victoza and Trulicity, 2 GLP-RAs, glucagon-like peptide receptor agonists. You're not supposed to be on more than one. It's the Trulicity is a weekly injection. Victoza is a daily injection. And the patient was just not receptive to that. My intervention of being like, you're not supposed to be on both. It was more of like, well, why would my doctor prescribe both of these if I'm not supposed to be taking them? And I was like, that'd be a question for them. But I ended up being like, okay, well, they're both covered with insurance. I don't recommend taking them both. But she was adamant about picking up both. So I said, okay, you can pick up both of them, but please don't inject both of them. I would recommend the Trulicity since it's a weekly dosing and not a daily dosing. I'm like, if you do both of them, you're gonna be really nauseous, you're gonna be throwing up. But at least the Victoza is like a daily and not like 2 weeklies together. That wouldn't be good. And then my last intervention that I can mention is I had a patient picking up both acyclovir and valcyclovir. So Varax and Valtrex. So 2 medications for herpes, be it like cold sores or genital herpes, and you're not supposed to be taking both. Valtrex is basically a prodrug version of acyclovir. It gets metabolized into acyclovir. It has a valine attached to it for better bioavailability, so you have less frequent dosing. I will mention I see this a lot when you put 2 medications in like a drug interaction app and it says no interactions found. That's not the case. It's not good to take both of these medications because it can cause some kidney problems because they both can cause crystal urea. Alright, so pharmacist interventions part 22. All 3 of these were from yesterday. I had a woman picking up Addy, A-D-D-Y-I, flibanserin. It's approved for hypoactive sexual desire disorder in premenopausal women. So it's an interesting little medication. It's a serotonin 1A agonist and then a 2A antagonist. Don't really know how it works. There are 7 classes of serotonin receptors and they each have like receptor subtypes. Serotonin 1A has a lot of activity. It has to do with thermoregulation, anxiolysis. It has to do with blood pressure and heart rate. Activity on this receptor has shown a decrease in impulsivity and aggression, and then it's also showed an increase in sociability and then also like sexual drive and arousal. It's also a receptor that deals with like sleep and nausea and stuff like that. Serotonin 1A receptors are on the blood vessels and in the CNS. Some of the other receptors within the different classes are on the GI tract, PNS, or peripheral nervous system, and the platelets. So Addie needs to be taken every single day in order for it to work. The patient that was picking it up had like no idea what this medication was, basically. I made a comment about like, oh yeah, make sure you don't drink it with alcohol. And she was like, what do you mean? And I was like, what do you mean? It's the black box warning, like you're not supposed to drink alcohol with it. It can cause severe hypotension or a drop in blood pressure, and syncope, which is fainting. This is the main counseling point with it. She said, well, I didn't know what my doctor was sending over. They didn't tell me, they just sent something over. I didn't even know I was picking this up today. So I was like, okay, let's talk about it for a little bit. So it's 100 milligrams. It's given at bedtime. If you're gonna drink alcohol, it can't be more than 3 drinks. If you're going to take your dose for that night, and then it has to be at least 2 hours after if you drink less than 3 drinks, or else, again, hypotension, and then syncope. It's also contraindicated with 3A4 moderate or severe inhibitors. One example of a moderate inhibitor is fluconazole or diflucan. This is not good if you take that with flubanserin. Out of like 15 patients in one of the trials that took 200 milligrams of diflucan, 20% had a severe drop in blood pressure and or syncope, and one of the 15 patients had a blood pressure of 64/41 and had to be transported to the emergency room. So I thought that was interesting. So again, Addie needs to be taken daily, and we don't really see effects until about like 4 weeks with taking it. I will say that the FDA originally declined the approval when it was originally submitted due to like basically the risks versus benefits. They needed more literature with that. And then after it was approved, it showed, it's like disputed whether or not it has like a clinically meaningful effect on patients. So about 10% of patients report like meaningful improvements. So it doesn't really help a whole lot of patients, but it is a newer medication. It's kind of expensive, but kind of interesting. So I talked to her about basically the alcohol interaction, when to take it. She thought she was supposed to take it like Viagra, like as needed. And I was like, no. Another intervention that I had yesterday, I had an infant with pneumonia, like a literal like 1-year-old with pneumonia. The dose that was sent over was ceftonir 125 per 5, 2.5 mils daily. I asked what the patient's weight was. It was 21 pounds. So I figured out that that dose was wrong. It was half the dose what it was supposed to be. It was supposed to be 5 mils daily or 2.5 mils twice a day. So we dose ceftonir by weight. So it's either 14 milligrams per kilogram daily or 7 milligrams per kilogram twice a day. So either the provider meant to send in the 250 per 5 concentration and like dose it like 2.5 daily, or they meant to send in like 2.5 twice a day. Either or, it was after hours. I told the caregiver to follow up with the pediatrician, and then I dispensed the medication so they could at least get it started. And I explained what the dosing should be. Last intervention yesterday was I had a patient, or I guess a caregiver, picking up ibuprofen 800 and aspirin 81 twice a day. It was for clot prevention after a surgery. It was just a basic counseling point of you have to take the aspirin 30 minutes before the ibuprofen, or you will not get its antiplatelet effects. Or I guess 8 hours after, but I recommend it like to take it, of course, before. Like 8 hours is like a weird timing window, especially if you're on the aspirin twice a day or dosing the ibuprofen more than like 2 or 3 times a day. So yeah, you need to take the aspirin before, because it's going to bind to the COX enzyme and then exhibit its antiplatelet effects. You need that for clot prevention. It's not good to not take it like that. So I think that was all 3 of my interventions for yesterday. Kind of wild day. Last intervention was today at a patient picking up AVQ 0.1 milligram. That is epinephrine. It was for a patient who had anaphylaxis. It's a 19-year-old female. That's the incorrect dose. If you're 33 pounds or less, that's the infant dosing. If you're less than 66 pounds, greater than 33 pounds, you do the 0.15 milligram. And if you're over 66 pounds, you do the 0.3 milligram. So she's picking up the infant dosing as an adult. So I called the hospital, and I was on hold for a while, talked to a few people, and then got transferred to a pharmacist. And I said, hey, can I do like an oral switch? Verbal switch to the correct dose. It was prescribed for the infant dose. She said, yeah, okay. So I switched it to the adult dose and got it for her. And I found this out because we were trying to order the AVQ. And then when I looked at it, I was like, that's not the right dose. But that's how I figured that one out. But those are my interventions recently. All right, so pharmacist interventions part 23. These were from yesterday and today. I had a patient yesterday, or a caregiver, picking up Abilify Maintena 300 milligrams, which is an injectable Abilify. It's an antipsychotic. It was flagging against Zyprexa and oral Abilify. So it had on the file that patient was on 2 other antipsychotics, oral formulations. So I asked the caregiver, patient was not on oral Zyprexa, but they had previously been on oral Abilify to assess tolerability. That's normal. It's recommended to be on the oral version before you do the injectable to make sure the patient's tolerating it. So I noticed the dose was kind of low. It was 1/2 of the 5 milligram tablet. So the patient was actually on 2.5 milligrams. So I just mentioned it to the caregiver to say, hey, this is kind of low. We're treating a patient with bipolar who was having psychosis, and it's recommended to pretty much be on the dose that you're gonna have therapeutic levels with if you're doing an injection. So a more appropriate dosage would have been like the 10 to 15 milligrams if we're at accurately wanting to assess tolerability. But that's just something I mentioned. It also requires an overlap too. Caregiver was not aware that it required an oral overlap is what we call it. So the lead-in is when you take something up to the injection, you inject it. Some antipsychotic injectables, you don't have to continue the oral one on top of the injection. So you take the injection and you stop taking the oral, but with the Abilify Maintena, you keep the injection. And then you keep the oral Abilify for 14 days, along with it to obtain therapeutic concentrations. This is different than the Aristata, the Abilify Aristata. There's a couple recommendations with that, but sometimes you keep the overlap longer. Another intervention I had was yesterday. I had a patient picking up or dropping off a prescription for Eliquis. It was the 5 milligram. It was 2 tablets twice a day for 30 days. It was from an ER physician. That dose is incorrect. He already did the load. The load is kind of a misnomer. It's not really a loading dose by definition, but we do have a higher Eliquis or Xarelto dose at the beginning. After someone has a clot, he had a DVT in his calf. So you do 2 tablets twice a day for a week, and then you change him to 1 tablet twice a day. So he was given the incorrect dose, 2 tablets twice a day just continually when it's supposed to be 1 tablet twice a day. For a DVT, if it's provoked, meaning we have a reason for it, treat 3 to 6 months. If not provoked, we usually do indefinitely for patients, or sometimes stop if the bleeding risks don't outweigh the benefits. All right, pharmacist interventions, part 24. I had a caregiver picking up a medication for a patient, and it flagged for CKD, chronic kidney disease. So the patient had CKD5. There are 5 stages of chronic kidney disease. Stage 5 is the last stage. This is renal failure or kidney failure. This patient was on dialysis, and the caregiver was picking up Crestor for the patient, or Rosuvastatin. Crestor is for hypercholesterolemia. It's a statin, and the dose was flagging for basically too high. So they're picking up only 20 milligrams, and the dose for patients with end-stage renal disease should be about 5 to 10 milligrams. So it wasn't too much of a difference, but I did counsel on signs of too high of levels, what that would present as. So I was is the patient experiencing any muscle pain, myalgia? And the caregiver was it's interesting that you ask that, because yeah, she's been having a lot of muscle pain, and that's why she's not here right now. She's waiting in the car. So I was oh, that's really interesting. So I recommended to follow up with the provider, and then maybe even do a CPK, a creatine phosphokinase. It's an enzyme that'll show up in labs in the blood if you have some muscle breakdown, which is what we worry about with statins at particularly the higher doses. I will say medications like Pravastatin and Crestor out of the statins have lower risk of muscle breakdown and myalgia, but the risk is still existent in some patients. So this has to do with hydrophilicity or lipophilicity. Hydrophilic medications are going to reside in the plasma usually, and lipophilic medications are usually going to reside in the tissue. So dialysis dosing can get pretty complicated. There are a couple different types of dialysis, intermittent and continuous, or CRRT, continuous renal replacement therapy, and a lot of CRRTs exist. So with intermittent dialysis, there's either hemodialysis or peritoneal dialysis. Hemodialysis you'll usually do maybe 3 times a week. It'll be a 4-hour session. Peritoneal dialysis is a lot more complicated, and there are a couple different types. Peritoneal dialysis will literally use the peritoneal lining in the abdominal cavity to filter out toxins and waste products. So CRRT, or continuous renal replacement therapy, is sometimes used in the hospital if a patient has an acute decline in renal function, particularly those who are too hemodynamically unstable to tolerate normal or standard hemodialysis. So it's also used sometimes with medication toxicities that have a high volume of distribution, tissue binding, plasma binding, and then also a longer half-life. Or if a medication has some sort of redistribution potential, like with lithium or methotrexate. So drug dosing and dialysis can be a little complicated sometimes, because sometimes dialysis will remove the drug and then redosing, you'll have to do that accordingly, or sometimes the medication is just like not removed at all by dialysis, and that can result in drug toxicity. So medications that are not really removed by dialysis are medications that have a high molecular weight, maybe something like filgrastim, or they have a high protein binding, so it's bound to protein in the plasma, so you can't really rip it out. So something like phenytoin, or medications that have a high volume of distribution. Volume of distribution is like a pharmacokinetics term that we use to kind of explain, like, is the drug going to reside in the plasma or the tissue? Is it? This can also relate to lipophilicity as well. So with dialysis, some examples of things that are pulled out are something like vitamins like B and C. That's why we supplement patients on dialysis with that. And then some medications that just are not pulled out are like colchicine. So colchicine is particularly like deadly in toxicity because treatment of that is largely like supportive. Like you can't remove it by dialysis. So colchicine is used for the acute treatment of gout. In a review of 150 patients with colchicine overdose ingestions, at the dose of 0.8 milligrams per kilogram resulted in 100% mortality. Some medications are partially removed by dialysis. So these are the patients that I pay a particular attention to, because I see a lot of prescriptions come through that are just improperly dosed for their creatinine clearance or their stage of kidney disease. So this can be bad because it can either be therapeutic failure or extreme toxicity and death. So I did mention a patient on my page who got baclofen that was basically dosed wrong, and I caught it and I put in a note, and then it just wiped out of the system because we changed the manufacturer, and then we had to re-verify it and another pharmacist didn't catch it. So the medication was adjusted, like the frequency was adjusted down, but it wasn't adjusted down enough, and this patient ended up going to the hospital for 5 days with baclofen toxicity and hallucinations. So it's very important to pay attention to this. I will say that rosuvastatin is a little interesting, and I believe that there's enough literature with recommendations of how to dose adjust it. It's interesting because it's a hydrophilic statin, and then it's also not heavily renally cleared, but it also exhibits high protein binding. So I thought that was an interesting intervention. All right, so pharmacist interventions part 25. I had a patient trying to pick up eplerenone and spironolactone at the same time. You can't take these together. This is contraindicated. They're both in the same drug class. They're potassium-sparing diuretics. I usually see them for use in heart failure to decrease morbidity and mortality. This patient specifically, I believe, had heart failure with reduced ejection fraction. In these patients, stage C, we like to put them on 4 medications. So first, an ARNI like Entresto, or maybe an ACE inhibitor like lisinopril. We add on a beta blocker like metoprolol. We tack on a mineralocorticoid receptor antagonist like eplerenone or spironolactone, and then an SGLT2 inhibitor like Farxiga. So this patient wasn't sure which one he should be on, and I talked about the differences between them. So eplerenone is less anti-androgenic. Spironolactone blocks androgen receptors, so it can cause gynecomastia and breast tenderness in males. So I talked about the differences between those, and then of course only recommended picking up one of them. It's not good to take both again because same drug class, they both increase potassium levels. So this is because they block the activity of aldosterone. Aldosterone is a mineralocorticoid. So its function is to increase sodium and water reabsorption and then cause potassium excretion. So when you block that activity, you increase potassium levels, which can be dangerous. Next intervention, I had a patient who was on the younger side trying to pick up an Eliquis starter pack. She had a blood clot in her arm. Insurance actually ended up paying for it, but it was legitimately $700. So I decided to call the hospital, and I got a hold of the operator. I'm like, hey, transfer me to inpatient pharmacy, because I like to talk to pharmacists to get like things done with coupons and stuff. So I talked to the pharmacist. I'm like, hey, can you enroll this patient real quick for the free trial card? Because I have databases at the hospital that they can just pull up sample cards and they'll just randomly auto-populate. And she gave it to me over the phone for this patient that was recently discharged. So these free trial cards are not available online. And then also retail pharmacists like can't call for them. They're like inpatient or like hospital or practitioner cards only. So I've asked before for Eliquis or Bristol Myers Squibb to give me those, and they said no. But I got this card for her real quick, and it was free. So it dropped from $700 to $0. So she picked up her Eliquis, and then I also talked to her about the $10 like copay card that she could enroll in for her continued fills, because she's going to be on it for a while because it was an unprovoked clot. The next intervention was I had a patient who was previously on Mounjaro 12.5, and then their provider switched them to Zepbound, but they ended up putting them on the 5 milligram. So Mounjaro and Zepbound are both tirzepatide. They're both the exact same medication, just different brands, different indications. So I talked to that patient like, hey, your dose got knocked down like twice, because it comes as 2.5, 5, 7.5, 10, 12.5, and 15. So their dose went down to basically 2 doses. So maybe the provider thought they were different drugs and was using the idea of incomplete cross tolerance. Cross tolerance is when you get, when a patient's tolerant on one medication and they're going to be tolerant to this, like another medication in the same drug class, but incomplete cross tolerance is they're not like fully tolerant to the medications within the same drug class. This is kind of like the term we use for opioids. Like when we change patients from opioid to opioid and they're tolerant on them, we'll usually decrease the dose by like 50%. But this was interesting. I told them basically their dose was chopped down. Last intervention was I had a patient picking up Vyzulta. It's a branded eye drop. It's relatively new. It's latanoprostene bunod. So it's basically a prodrug into 2 different drugs, basically latanoprost and then butane mononitrate. So 2 different mechanisms. It's used for glaucoma. It was $500 for this patient, and I don't believe she's trialed really anything else for her glaucoma, but she was paying out $500 like every single month. And I brought up, hey, maybe you could try latanoprost, which is usually first line therapy with glaucoma. It's $5 to $10 with a GoodRx, and it is one of the metabolites of Vyzulta. So I don't believe that there's a huge difference clinically between Vyzulta and latanoprost. Vyzulta is a little bit better, but we're still going to get that aqueous humor decrease with both of them. So this decrease in aqueous humor is due to increase in outflow, and then it also decreases intraocular pressure, which is what we need in glaucoma. All right, so pharmacist interventions part 27. So I had an office call me today about a Zofran prescription that was on hold that wasn't filled, and she's wondering why it wasn't filled. So I looked back at the notes, and there was an interaction that flagged with another medication or 2 for QT prolongation. So QT prolongation is something that can happen with patients who either have risk factors like electrolyte abnormalities, long QT. There are some like issues with like higher age, and then if you're of the female sex. But it's like basically it can lead to an abnormal heart rhythm. Something called like torsades de pointes can cause sudden death sometimes. So that's actually what my EKG tattoo is. So this patient was kind of on a lot of medications. The hydroxyzine was on hold. This patient was on promethazine chronically, and I'll go into that in a second. Their quetiapine dosing was around 300 milligrams, and then the Zofran that was sent in was like scheduled like 3 times a day for like a 30-day supply. The azithromycin was a recent order that was picked up. Usually I see it for URTR, and I think that's probably what we were using it for. So upper respiratory tract infection. So when this flags, I'll usually consult on something like palpitations, dizziness, syncope, or fainting. But some patients are actually asymptomatic. Some of these medications have a relatively like low risk with QT prolongation as opposed to something like antiarrhythmic medications. But of course, when you start like stacking them on top of each other, the risk increases. I think it was a nurse on the phone, but I asked if they had like a baseline EKG or if they were doing like any like periodic EKGs for this patient. She was on all these medications, and then she also had 2 risk factors that I caught, which were like being of higher age and then also female sex. Those are both risk factors for QT prolongation. She's taking a bunch of notes, and she said she would talk to the provider and get back to me. I had her on the phone, so I went ahead and asked my other questions because I saw that she's on a bunch of sedating medications, like a moderate dose of the Seroquel. She's also like possibly on as needed or like even scheduled hydroxyzine. And then we have this promethazine that was an area of interest for me. This patient was on both promethazine tablets and promethazine dextromethorphan syrup, like chronically, like every single month on both of them. She was paying insurance on some of the fills and then paying out of pocket on a lot of the other fills. And then I also noticed I didn't have a diagnosis code for like any sort of like nausea related condition. So I clarified to make sure the patient wasn't on like any chemo, even though like promethazine or any of this wouldn't really be an appropriate like chemo-induced nausea vomiting like regimen anyway. Our pharmacy actually got a lot of fake prescriptions for promethazine. I actually had like a couple verbals like personally where people were using providers' NPIs. Like one NPI someone used was like a urologist's NPI for like a whole pint of promethazine with a crap ton of refills, like no diagnosis code, calling it in as promethazine plain. I was like, I couldn't understand what that second word was. Like, what are you saying? And then I figured out it was promethazine plain because that's what it says on like Google Images, but I've never even like like saw that on the bottle, but it does say it on the bottle, I guess. Definitely a noob calling it in, because promethazine DM, that's where it's at. But I called promethazine with DM lean light. So lean or purple drink is like promethazine with codeine, but that got taken out of all the pharmacies due to all the fake prescriptions. Also weird is I literally had a dream that this patient was having fake prescriptions for promethazine come in, just because I guess I was thinking about it. So since I had the nurse on the phone, I brought up the abuse potential with promethazine, and she mentioned that this patient actually did have a history of like some sort of drug abuse. I've never seen her in person. It's always caregivers picking up for her. But anyway, I asked them what the promethazine was for, and they said it was for nausea related to the Seroquel. So then I asked what the antipsychotic was for, because I didn't see any like psychotic diagnosis on file. All right, Pharmacist Interventions Part 26. Oh my goodness, I had this guy call me yesterday and he told me he was out of his blood pressure medication and he didn't know what any of his medications were for, by the way. So I went through him, like every single one on his list, and the one he wasn't out of was actually his blood pressure medication, his losartan hydrochlorothiazide. So I was telling him what all his meds were for, and he was telling me about how he had a recent like urgent care clinic visit and how his heart rate was in the 30s. And I was like, well, you're on metoprolol. This is a beta blocker. It drops your heart rate. And he's like, and I asked him what he was using it for. He's like, yeah, for my heart rate to increase. I'm like, no. That decreases your heart rate. You're not supposed to be on that if you have bradycardia or anything like that. So we had that little talk, and I ended up faxing his doctor for refills on his medications. And the doctor was really quick to respond. I think it was because it was a Sunday. But he left me a verbal for metoprolol and montelukast. So I was like, which is singular, for his allergies. So I was like, okay. I think he was mixing up his singular with his blood pressure medication, but I was like, okay. So because he responded so fast, I faxed him back and was like, hey, this patient told me his blood pressure was like in the 30s last time he was at this clinic appointment. Like, what is this metoprolol for? Like, are you aware of this? He calls back and leaves a verbal, like, just like, not a verbal prescription, but a message, and goes, oh yeah, I don't know what he's on that for. I'm just continuing care for his pulmonologist. And I was like, I felt like the Chick-fil-A girl. I was like, what do you mean in my head I was like, what do you mean you're prescribing this medication? You don't know what it's for. Like, how are we supposed to weigh costs versus benefits? Like, are we treating the disease state, like, adequately? Is the patient having any side effects? Like, it was just wild to me. Like, a labeled contraindication to metoprolol is, like, a heart rate less than 45. And we don't even, like, usually initiate it in patients who have heart failure if the heart rate drops, like, below 55. So I ended up sending a fax to the pulmonologist, like, asking what it was for and telling him about the bradycardia. But, like, thinking today, I'm like, I couldn't even tell you what a pulmonologist was prescribing a beta blocker for this man, like, for. Because, like, its use in, like, pulmonary arterial hypertension is, like, not recommended by, like, any guidelines. And I was like, is this, like, for, like, something else? Like, I couldn't even, like, tell you what it was for. When I see metoprolol or a beta blocker, I think usually, like, it's for blood pressure. Even though it's not, like, a first-line option unless you have, like, heart failure or history of a myocardial infarction, like, a heart attack, or if you have, like, AFib. But I'll also mention, like, first-line options are, like, thiazides, like hydrochlorothiazide, ACEs and ARBs, like lisinopril or valsartan, and then, like, calcium channel blockers, like amlodipine. So, like, a second intervention I can talk about is a resident physician from, like, the hospital across the street sent in a prescription for tussin. So if you don't know what that is, it's over-the-counter, it's guaifenesin, it's kind of like Mucinex. And the patient came in, and it was on hold because it wasn't covered, it was over-the-counter, and she's like, what do you mean it's on hold? Like, I think she was, like, a nurse or some sort of healthcare provider, and she was meaning to get Tussinex. So Tussinex is an opioid. It's hydrocodone and chlorpheniramine, which is the first generation antihistamine. So, like, I had to call the hospital, and, like, I got a hold of this physician, and I was like, you sent in the wrong thing. Like, Tussin and Tussinex are completely different medications. I thought that was, like, a really pretty bad mistake. Like, what if it was, like, flipped? What if, like, I had a pediatric patient get prescribed, like, Tussinex instead of, like, Tussin, and, like, what if that, like, killed them? But those are just a couple examples of, like, what not to do as, like, a provider, I guess, is, like, you have to know the medications you're prescribing. Like, that's, like, you just have to. Like, I couldn't imagine prescribing a medication that, like, I either don't know what it is or, like, what it's being used for. Like, in Indiana, we can prescribe, like, birth control and, like, tobacco cessation and stuff like that. Like, you have to make sure it's appropriate for the disease state and it's not interacting, like, it's not having any, like, side effects for the patient. Like, you have to make sure therapy is optimized. Doses for a lot of medications depend on what you're using it for. But anyway, I asked them what the promethazine was for, and they said it was for nausea related to the Seroquel. So then I asked what the antipsychotic was for, because I didn't see any, like, psychotic diagnosis on file. We usually use Seroquel for something like bipolar or schizophrenia. It has a lot of side effects. I asked if the patient had a psychiatrist, and she said no, and it was was a primary care provider prescribing all these medications. The patient seemed to be like new to the clinic. It seemed to be some sort of like transition of care, but I think they were trying to get her off of the promethazine and like onto the Zofran. I was like low-key surprised to see that insurance covered that, like 3 a day for like a 30-day supply. So I did mention that it might be like good to reevaluate the usage of this medication like outside of a like psychotic diagnosis, and then really go through like risks versus benefits for the patient. This medication can increase cholesterol and triglycerides, and then can also increase blood sugar, which is the risk for diabetes. It can increase appetite and then also increase weight gain. There's a lot of different mechanisms that play into this, but for example, one mechanism is serotonin 2C antagonism. We see weight gain with most antipsychotics, but I will say ziprasidone, Latuda, and Caplyta have the lowest risk. One thing about Seroquel is it's pretty heavily sedating and has a high incidence of somnolence. If we look at my chart, this has to do a lot with its antihistamine activity, H1. It can also cause dizziness, which can increase the risk for falls and subsequently fractures. It has 2 black box warnings. One is increased risk of death in patients who have dementia-related psychosis. This is usually cardiovascular related, like with heart failure or sudden death, and then also with like pneumonia, specifically aspiration pneumonia. Its second black box warning is increased risk of suicidal behaviors and thoughts, specifically in pediatrics and young adults. Right here, the second receptor, we see alpha-1. It blocks that receptor, which can increase the risk for orthostatic hypotension, which is when you get up and your blood pressure suddenly drops. So that can cause like some dizziness and fainting. I like charts like this because it tells you how potent it is at each receptor, which is how you can derive like what it's being used for, or like side effects. We see its activity on muscarinic receptors here, so it's anti-muscarinic or anticholinergic. So we can see side effects like dry mouth, blurry vision, constipation, and urinary retention. Antipsychotics block dopamine receptors, which is where we assume we get its usage for psychotic symptoms like hallucinations and psychosis. This dopamine blockade can also cause EPS side effects or extrapyramidal symptoms like drug-induced Parkinsonism or restlessness, tremor, and stiffness. I will mention that second-generation antipsychotics do have a lower risk of EPS and like Tordive as opposed to first-generation antipsychotics. This is said to be due to its antagonism on serotonin 2A receptors. This also helps with negative symptoms of schizophrenia. I'll also mention that some rare side effects of Seroquel are QT prolongation and torsades de pointes, seizures, and then leukopenia, which is a decrease in white blood cells. I will also mention that Seroquel does have an abuse potential. It can also increase the risk for respiratory depression, specifically in like overdoses or combination with other medications like opioids. So this patient was on 2 antihistamines, hydroxy and promethazine, and then a drug that has antihistamine activity, quetiapine. All 3 of those medications are sedating, and then I'll also add that promethazine also blocks dopamine receptors. So the main thing with this pharmacist intervention was 1, recognize the risk of QT prolongation with all of these medications combined in a patient who has 2 identified risk factors, being of higher age and of the female sex. Implement EKG monitoring if appropriate. Number 2, reassess the costs versus benefits of using quetiapine at a moderate dosing in a patient with non-psychotic symptoms. Refer if appropriate. Number 3, reassess the usage of chronic promethazine in a patient with a history of drug abuse. Consider alternative or better therapies with lower side effect risk. And also with that, reassess the diagnosis of nausea in this patient. Make sure it's an appropriate diagnosis and then that nausea is being appropriately managed. Nausea is not an incredibly common side effect of Seroquel, but it does happen in some patients and can get better as you take the drug. Alright, so pharmacist interventions part 28, since I haven't done one in a while. Today I had a patient who is 80 years old get prescribed Admelog, short-acting insulin, prescribed at 100 units 3 times a day before meals, and I've seen doses like much larger than that, but I always like to check like old prescriptions to see if they're usually on that dose, and they weren't like regularly at that dose. The prescription that was sent in was for Humalog, which is also insulin Lispro, short-acting insulin, and it was for 3 units 3 times a day before. I was like, that's a little sus. So I called the office and talked to one of the nurses, and she was shocked. She was like, oh yeah, let me follow up with the provider. And then like maybe like half an hour to an hour later, another prescription came in for Lispro, and it said 3 units 3 times a day, cancel the old prescription, or like cancel the recent order. So they accidentally sent in like the wrong dose. I don't know how they sent in 100 units 3 times a day instead of like 3, because that was like a big jump. But I caught it before it went through like data entry verification. It would have flagged for the dose, but like the excessive doses that flag are often like overridden just due to like alert fatigue. And then also like sometimes the daily dose is calculated incorrectly because it's the quantity divided by the day supply, but sometimes insurance limits day supplies to like 30 days and stuff. So it's pretty common to see excessive dose flags in the pharmacy. I also mentioned the patient had a glucagon pen that was on hold that wasn't covered with insurance. That was sent in like a month or two ago. Another intervention, I had an older male patient get prescribed ciprofloxacin twice a day for 2 weeks and then also Levaquin daily for 2 weeks. So you need to be careful, of course, when prescribing fluoroquinolones in general, but this patient was getting 2 fluoroquinolones when I can't think of any indication that would warrant dual therapy with 2 fluoroquinolones. Patient didn't know what they were supposed to be picking up. I told them that they only needed one of the fluoroquinolones. It seemed to be some sort of incision site infection, but I stressed to him you only need one of these, don't take both of these. And then he followed up a week later and was like, yeah, I don't know why my provider sent that in. I followed up with them. I was only supposed to be on one of them. So def gotta be careful with fluoroquinolones because of how toxic they can be. Their side effect profile is not very good. I've talked about it on my page before, but remember, black box warning of serious side effects like tendon rupture, peripheral neuropathy, CNS effects, which Cipro has more CNS effects over levofloxacin. So some side effects that can happen: seizures, insomnia, depression, anxiety, and hallucinations. Some paresthesias too, like numbness, tingling, pins and needles. The last intervention I wanted to mention was I had a patient who had tuberculosis. We were treating it with RIPE therapy, so rifampin, isoniazid, pyrazinamide, ethambutol. We use all 4 medications as an intensive phase for 2 months, and then for 4 months we use rifampin and isoniazid. Important to note that these medications can be hepatotoxic, can be hard on the liver, namely the rifampin and the isoniazid. I was entering the prescriptions and I noticed the E said entecavir and not ethambutol. So for those who don't know, entecavir is usually what we use for Hep B. So hepatitis B, this is a viral hepatitis. It's due to a virus. It affects the liver. It is non-curative, so you cannot cure Hep B. Important to note that not everyone with hepatitis B gets actual treatment for it, and then also there's a vaccine for it. It's preventative. It's given as a series, and it's to my knowledge the only vaccination that we give upon birth. It actually wasn't recommended for routine vaccination until the 90s by the CDC's ACIP, or Advisory Committee on Immunization Practices. So a lot of people in their 40s and above have never been vaccinated for Hep B, fun fact. But anyway, I called the provider, I left a message with the staff, and the provider eventually called me back. She said that the E was supposed to be ethambutol, and then she meant to write another prescription for entecavir. The patient was finishing out the intensive phase, so they just needed another few doses of the ethambutol. So I took a verbal for the entecavir too, and then I asked the provider, is the patient aware of their Hep B? And she told me she didn't know. I thought that was interesting that the patient was unaware of their diagnosis. I see that a lot in retail, which is concerning. I might make a video on it later, but I do have a lot of patients that are unaware of what they're diagnosed with and the diagnoses that they have on file. I think healthcare providers need to be better with open communication with patients, and if we're giving someone a diagnosis, we need to tell them what we're diagnosing them with. But yeah, in other instances, I had a patient the other day picking up an antibiotic, and it flagged for too low of dose. It was tinidazole, 500 milligrams dosed daily, and I've never seen that dose before, and everything on all of my apps were showing that the dose should be 2 grams once for different parasitic infections or trich. I asked her what she was using it for, and she's like, oh, a bacterial infection. And I was like, well, what kind of bacterial infection? And she had no idea. So I was like, okay, well, we need to follow up with your provider to make sure that this dose is appropriate for what we're trying to treat. We need to make sure that we're not underdosing patients. But that was my attempt at an intervention there. All right, pharmacist interventions part 29. I had a patient prescribed methamphetamine or disoxin. This isn't a common medication to be prescribed. It's C2. It's for obesity and ADHD. So I asked him what he was using it for. And I asked if he had a trial failure of Adderall or something, and he did. And I asked why. And he said he was having tremors. It made me chuckle, but I told him he's likely to have tremors on the methamphetamine. Next on my list, I had a patient who's on 180 milligrams of diltiazem twice a day. This is a non-dihydropyridine calcium channel blocker. It's sometimes used for angina, arrhythmias, sometimes for hypertension. This patient was also on ranolazine, which is used for angina. She was on 500 milligrams twice a day, but then the provider bumped her up to the max dose, 1,000 milligrams twice a day. The thing is with this, when you pair ranolazine with something like a 3A4 inhibitor, a moderate or strong inhibitor, you can't be on that dose. Diltiazem is a moderate 3A4 inhibitor, so the max dose of someone on that dose of diltiazem with the ranolazine is actually what she was previously on, the 500 milligrams twice a day. So in that one, I called the office and had them discontinue the 1,000 twice a day that they just moved her up to and just bump her back down to the 500. Another pharmacist intervention is I had a woman in her 60s prescribed Oxy 10 milligrams every 4 hours after an acute surgical procedure. This is 90 MME or morphine milliequivalents. This is a large dose for an opioid-naive patient. In this situation, I recommended splitting the tablets and taking it every 6 hours as needed. Next intervention, I had a patient picking up Brilinta or ticagrelor. It's a nucleoside analog P2Y12 inhibitor. It's an antiplatelet. We'll use it sometimes in like dual antiplatelet therapy after someone has like a heart attack. It's used with unstable angina and STEMIs after PCI or percutaneous coronary interventions. So PCIs, we dig on in there, put in a stent. We don't want platelets adhering to this stent and like causing a thrombosis. It can also be used for prevention in patients who are at high risk of heart attack and stroke, and or in patients who have already had a stroke as like secondary prophylaxis or secondary prevention. Little tangent, but this is the Plato trial. It compares ticagrelor or Brilinta to Plavix or clopidogrel. The rate of death from any cause was also reduced with ticagrelor, 4.5% versus 5.9% with clopidogrel. That was the important part of this trial, showing that it was superior to clopidogrel with regard to mortality. Also important to note, an increase in the rate of non-procedural related bleeding. It's a more potent antiplatelet. I guess a few other random things. This study was funded by AstraZeneca, the manufacturer. Ticagrelor doesn't have as many like drug interactions as clopidogrel does. One most important being omeprazole or Prilosec being a 2C19 inhibitor. It decreases the activation of clopidogrel. This is also important for poor 2C19 metabolizers. I digress. But the pharmacist intervention on this one is that it was dosed daily. Brilinta is a twice-a-day medication. This patient was actually on it for like a few months before I caught it. It was at a store that I was like floating to, so I'm not sure how like it wasn't like flagging in the system or something. But yeah, that's not good. Clopidogrel or Plavix is daily. Brilinta is twice a day. Okay, pharmacist interventions part 30. I had a patient picking up gabapentin capsules and it flagged for a pork allergy. Usually when it flags for a pork allergy, it's a religious intolerance, which it was in this case when I talked to the patient. You can go to dailymed.com to look at excipient or non-active ingredient lists. But anyway, I faxed the doctor for an alternative because this patient did not want to pick it up once they found out there was gelatin in it or pork. Another pharmacist intervention, I had a patient on both meloxicam 7.5 milligrams daily and naproxen 500 milligrams twice a day. It is not recommended to be on 2 NSAIDs at the same time. This patient was on both for like a few months and it was prescribed by the same doctor. I was working at a different store that day and I caught that and then I talked to them. I asked them if they had any like blood in the stool or like some stomach pain, and they reported like in the past yes, and then they stopped taking the naproxen. And the problems resolved when they stopped taking it, but I ended up inactivating the naproxen prescription and telling them like, yeah, you weren't supposed to be on both of those at the same time. Another pharmacist intervention, I had a patient prescribed cortisporin TC, which is colistin and neomycin, 2 antibiotics and hydrocortisone. Basically, it's a steroid. It's used for bacterial otitis externa, which is like an outer ear infection. Not only was it $100 and something I didn't have in stock, this patient also had a perforated eardrum. It's not recommended to use aminoglycosides in patients who have a perforated eardrum, an aminoglycoside being the neomycin. Aminoglycosides can cause some ototoxicity, so they're ototoxic, toxic to the ear. At the absolute worst, these medications can cause deafness. I recommended a switch to Ciprodex just to be safe. It's a fluoroquinolone and dexamethasone. It also ended up being $10 for the patient. Another pharmacist intervention that I had recently was I had a patient picking up triazolam, which is Halcyon. It's a short-acting benzodiazepine. We use it for procedural sedation with like tooth extractions. Sometimes it's used for insomnia, but that's a separate discussion. He was currently on Genvoya, which is an HIV medication. Genvoya is a mix of 4 medications. We have elvitegravir, which is an integrase inhibitor. We have tenofovir, alafenamide fumarate, and emtricitabine, which are both nucleotide reverse transcriptase inhibitors, a purine and pyrimidine analog, respectively. And then we have cabisistat, which is a CYP3A4 inhibitor or a pharmacokinetic enhancer or PK booster. I've talked about this on my page before, but we add PK boosters to drugs to extend the duration of action and half-life of medications that are degraded by certain enzymes like 3A4 or elvitegravir in this case. CYP3A4 is the major enzyme that metabolizes a majority of medications. Halcyon or triazolam being one of them. So basically he was being prescribed a benzo and the cabisistat in the Genvoya was inhibiting the metabolism of it. This will greatly increase concentrations in the body leading to overdose. I'll slip in here that patients rarely die from overdose on benzos alone. I didn't want my patient to be overly sedated and then sedated for an extended period of time, so I recommended that he skipped his Genvoya dose. I'll also mention that missing like 1 dose of an HIV med will rarely result in treatment failure.